So it has the iliac crest, then sagittal plane. Sure, get that center to my tube. I want to make sure that his MSP is parallel to the table here. So this looks just like your KUBs, right?
Mm-hmm.
So here's his xiphoid process. So I'm at T10, T11. I want the collimation on the shield, the light collimation on the shield. So I'm going to make sure and just have it at the edge. Okay, now what do I need to do? And collimate. So except for those of you that are at, I guess, Kaiser and, well, Sentinel, that nobody's there right now. So what else should we be doing? Flex the legs to help, one, for patient comfort. And what's the other reason?
Put it closer to the eye.
Yeah,
closer to the eye.
lordotic curve. Exactly. So it opens up the joint spaces by reducing lordotic curve. It got chilly in here. I'm cold now. I want my muffler back.
Do you want me to go get?
No, it's okay. I'll be moving around in a minute. I'm sure I'll be okay. Okay, so I'm just going to put my marker right here, or you can put it halfway. But you don't want it down on this end, because if you do that, the SI joints you may get your blocker in the SI joints. Okay, so I'm going to switch now from the LS spine to the L spine. LSP, no SS. So to do that, I need to center where?
1 inch
below the iliac.
above
I'm doing
the
the
iliac.
lumbar spine. So there were 2 inches. Yeah, 2 inches above the iliac crest, 3 fingers. Then I'm going to collimate down to 14, because now I'm using 11 by 14 instead of 14 by 17.
The other one was
LS spine. This is an L spine.
oh, LS one.
Yeah.
Okay.
So the LS spine is a bigger film. The L spine is a smaller film.
Yeah.
Okay, and then the blocker stays down. Questions?
L spine?
Yes.
So it's LSS.
No, that's too many S's. LS means lumbar sacral, SP. So it's LS spine or L spine. Lumbar spine or lumbar sacral. When we're including the sacrum, we need to have 17 inches of collimation. We go through this every time, huh? Okay, questions? Got it?
1 inch.
2 inches above the iliac crest.
Okay, 2 inches. Okay.
3 fingers. And I'll show you on the films today the difference between using a 14 by 17 and 11 by 14.
11 to 14.
Okay, so what should I do next? Which position? Well, but we have one more AP to do. What's that? Yes, L5S1 AP spot, otherwise known as the hips.
Hips.
What do you call hugs? Hugs?
Your pointer.
I got it, yeah.
Okay, I was
I just like,
I brought it in on
oh, it's
purpose.
in here. I thought it was on my pocket. Okay, so we're going to use a 10 by 12 crosswise. Okay, so how much did I angle my tube?
15
30.
30.
30 to 35 for this one. Remember, we're trying to get through that L5S1 joint space. Okay, now I've had to bring my tube distance down because of my severe angle. Remember that whole rule about the 5 degrees, 1 inch change in SID? So now I'm at 40 inches, but it looks like over here that the tube is between 34 and 30 inches. Where the little line is over here. But it's because of the distance here. So I've angled my tube. Next thing I need to do is what?
bucket.
Right. Make sure my bucky is centered. And I would suggest you move the table out of your way so you can actually see the light. Because the light here is different on the cassette. Because there's another 2 inches. So you want to make sure that this light hits the middle of your cassette here. Okay? Alright, so now that's done. Now I'm going to center to my part. And where do I center for an L5S1?
L5S1.
Well, more specific. If you can't feel that.
2 inches above the cubic.
Which is? Right at?
ASIS.
2 inches below the.
Okay, let me show you something here. We're centering at right below, well, we're centering actually 1 inch below the ASIS.
1 inch.
But because of the severe angle, the light is going to skim the ASIS here. So here's this ASIS. See how it's skimming right here through the part? But if I drew a straight line, see how it's slightly below? So here's this ASIS. Here's this pubic symphysis. We're halfway in between.
So it's 2 inches.
1 inches.
Well, they consider,
Oh, okay.
yeah, it's
Between-
1 inch because this is supposed to be about a 2-inch distance.
Okay,
Depends
so
on the patient.
between
ASIS or ASIS?
ASIS. So I'm skimming the ASIS here, but my actual entering point is about just slightly below. Like, remember the absent clavicle, how we had to
Yeah.
go slightly below to get through the part?
Yeah, but so we center first with the ASIS, or
Well, here's this ASIS right here.
I didn't follow what you did.
What I'm
Okay.
showing you is that the light is skimming through this way because it's angled,
Right.
but where it actually enters is below this line. See, here's this ASIS right here. See that?
Okay.
But see where the central ray is actually entering over there?
Yeah.
But it's skimming right through the part here. See how it's hitting it here with the light?
Okay.
All right. And then since I'm doing L5S1, I'm going to collimate down fairly close, about a 4 by 4 inch collimation, because we're only really looking for the L5S1. So again, you want to use the shielding, especially on males. So the thing with where they are showing you how to flex the knees, you have to be careful, because see what happens now? The more you flex the knees, the shield's going to get into your field of view. This is a much better shield to use. Where'd that other one end up? In the
I
drawer?
think they always put it back.
This one, the problem with using this is look what happens. See, it won't stay in place. So you have to just use the apron instead. See, now I can still shield the gonads, but not get the shield in the way of the light. Now this is the exact same position for one other exam.
Sacrum?
Yeah, SI joint, AP axial. Except I'll show you for that one we're going to center just a little bit lower. But we'll get to that in a minute. Let me finish the L-spine. Okay, so now I've done the AP and AP axial. What's the next projection to do? So blank.
Legs.
Okay, so before I have him turn towards his right, and I will always do the right oblique before the left oblique. Why do you think that is?
Because you could do. You have to do the lateral on
Right.
left.
So you want to think about your patient and their comfort because they're going to have back pain, so move them as little as possible. So if he's in the RPO now, then he'll go LPO and then left lateral. So I'm going to have him move away from me a little bit so as he turns, his body still ends up in the middle of the table. Now, as we use the sponge, remember this is the 45-degree angle here, not this one. Okay? You're going to put the edge like on the other side of his body, pretty far in, so then when he rolls back, the whole body rolls as a unit. What you want to look at is the hip and the shoulder 45 degrees from the table. You don't want the hip up too high, and you don't want the shoulder like this. You want the whole trunk in the same plane. Now, with Erica, she's, womanly, she's got more stuff back here. So, when I roll her up, when you have someone who's got stuff back here, you may have to put the angle, sponge at a slight angle so that when you roll them back, you're still in the same unit. Because when you roll back, you're going to have more back here to stop you from rolling. Follow? That's why you have to work with your patients. Everybody's a little bit different. And since he's male, we can just keep it the same. Now, where do we put the arm? Want to give this to her?
On the chest?
Well, either way, if you get it out of the field, it's okay along their side. The problem here is if you do this, sometimes you'll roll the shoulders up too much. Or if you do this and don't have the sponge back there, they tend to lay down too flat. So again, just make sure the whole body stays as a 45-degree rotation. So I always did this, but I know they show you in the book to have the arm up and over.
Talk about this?
No, but I will, thank you. Okay, so this is always on an 11 by 14.
Yeah.
Yes. So here's my... Okay, now in the RPO, the blocker's always down. The marker and the blocker are going to be on the side you're turning the patient towards. So in the RPO, the blocker's down, and I'm going to have the right marker on the right side. Okay? Set up. Okay, so now here's the magic. Here's where the magic comes. 3 fingers, 2 inches. You take the edge of your finger, put it at the iliac crest, and then bring your fingers alongside, and the central ray should be right next to your other finger. You see that? So this is the edge of my finger here on the iliac crest, and then I just go 1, 2, 3, and then the central ray goes right next to the other finger. Okay, so that's 2 inches above the iliac crest. Now be careful with your hand. When you're doing this, you want to just kind of touch with the pads of your fingers. You want it to be firm, like a Caesar Milan touch, right? But not too like touchy-feely. You don't want to be all like, oh, because then they won't know what's going on. You want them to know you mean business, but not push so hard that you're hurting them. Just like, I need to feel for your hip bone and tell them what you're doing. Because, you know, as you know for yourselves now, you're being touched by each other. It's kind of a weird thing, right? Especially if someone just starts jabbing at you, you don't know why or what's going on. So you got to communicate with your patient. Or that's where misunderstandings can come up. So 3 fingers here. Now the other part is I take the same 3 fingers. Edge of my finger is going to go right at his ASIS here. And then 3 fingers, and then the other line ends up right here. So 3 fingers up from the iliac crest, 3 fingers in from the ASIS. 3 fingers, 3 fingers. Now this will work on anybody, even a patient who's got a huge abdomen. I've done this where I've had like this much light on my patient because their abdomen was so big that it was like this. I'm thinking, oh boy, I couldn't possibly get that whole spine on there. So I want to, what's your inclination? You want to open the collimator, right? But that's not going to change the size of your image receptor on the bottom. As long as your crosshairs are in the right place, you'll be fine. Now look what happens. Where did this crosshair end up?
Ear.
Yeah, at his earlobe.
And it's side off. What do you call that?
What are we checking for here? What's the light demonstrating?
Oblique numbers.
No. Foramen to the lateral.
Zygopophyseal.
Zygopophyseal articulations. Just call them zygos for short. Which ones are we demonstrating?
Down.
The furthest one away.
Down.
No.
The left side.
Down.
The side down. Remember, side up.
Side up.
Stay with me here. Side up.
Side up.
Side down. Side up. Side up, foramen. Side down, zygos in the lumbar. Side up, SI joints. So now which zygos are we demonstrating?
Down.
The right side.
The right side.
The right side's down, it's the right side zygos. Okay? You know, when I came for a job here, that was one of the interview questions. Which position best demonstrates the right zygopophyseal articulations? They wanted to know if I knew positioning. You ask a tech that, they may not know. They just know they do this position. They don't know why they do it. Okay, so we'll collimate in side to side. I'm going to use my right marker because it's the right side down. Of course, we want to shield for the gonads. Okay?
Right cycle.
Now I'm going to do the opposite side. So turn it towards me. All right. And now scoot over towards me a little bit, and then roll up towards your left. And back. Now what I usually have them do is either straighten their leg out or just slightly flex their knee, because if you do this too much, see what happens? It brings the pelvis into a lateral. So you want to just have them kind of straighten this leg out. Let me bring it up again. Okay. So go ahead and put your arm by your side. Your pelvis is up too much again. It always happens on this side for some reason. Okay. Now see how he's kind of crooked? And that always seems to happen when we go to the LPO. His mid-sagittal plane is going this way. So I need to fix that. I want his mid-sagittal plane parallel to the image receptor. somehow when you turn them to the lateral, sometimes they end up laying like this. But you don't want the part going diagonal in your film. You want the part being parallel. So I'm going to recenter him a little bit. And the easiest way to do it is just to move the pad. You have to scoot his hip, scoot his shoulder, scoot his skin, take forever.
Dancing?
Plus, their back hurts. They may not be able to move that well. Okay, so same thing. See, iliac crest, 3 fingers up. Okay. ASIS, 3 fingers in. Now be careful again with your hands. There's stuff you don't want to start laying your arms down against their body. Just use the pad of your fingertips. Okay? So 3 fingers up from the iliac crest, 3 fingers in from the ASIS. Notice that the line is level with his earlobe. We can shield, so we should. And I would shield males or females. Just take the shield to the bottom of the light there. You don't have to have it in the light field.
So the blocker on this was posted.
Now the blocker's going to be up. So we're going to turn it so blocker's up because he's turned towards the left side. And I'll show you on the radiographs later why that makes a difference. And I know you don't have blockers even at the hospital anymore, but it used to make a difference. So, LPO, so I'm going to mark the left side. Now I'm going to keep my blocker away from this area because we're also demonstrating SI joints. That's why they call it an LS spine. In some hospitals, they don't do separate SI obliques. They just include it in as part of the lumbar series.
Right, for left cycle.
Yes, so this is for the left side apophyseal. Questions? I'll be quiet today. Okay, what's next? Lateral. Lateral. So go ahead and all the way up on your left side. Let's get you comfortable here. All right, so we want to make sure his shoulders and his hips are my hands perpendicular to the table. And people have a tendency to roll this way because it hurts. Erica's hip was starting to bother her because I had her on her side so long. Remember, people that have back pain, they may have had hip replacements. They can't really lay on the trochanters very long. Okay, so you want to make sure that the pelvis is perpendicular to the table and the shoulders. You can help by putting a sponge between the legs. What that does is it puts the femurs parallel so it doesn't pull so much on the lower back. Gets the hips more level. Okay, so where do I center for the LS spine on the lateral? LS, lumbar sacral spine.
3 inches inferior.
At the, okay, on the 14 by 17 AP, what do we center at? Yes, so on the lateral, where are we going to center? Iliac crest, exactly. See the connection? 14 by 17, iliac crest. Okay, so I'm iliac crest. Now where's my front to back centering going to be? That's the top to bottom.
1 inch posterior.
Nope, right at the midcoronal plane.
Oh.
You're thinking of the spot film. Right now we're right at the MCP.
Feel like alphabet soup in my head right now.
MCP, MSP, ASIS. Okay, so the last thing we're going to do here is I'm at the midcoronal plane. You've all done a lateral chest. You know where the MCP is.
Yeah.
Okay, now we're going to collimate in side to side. You don't need to see light back here. You don't need to see soft tissue. Remember, the spine's going to go in and then back. So you're going to collimate just inside the soft tissue. As long as you're at the MCP, you need probably about 5 inches of collimation side to side. See that? Don't get thrown off by the soft tissue that they have here or over here. As long as you're centered at the MCP, you should be good to go. So iliac crest, MCP. This is LS spine, lumbar sacral, 14 by 17. Okay, now, for women and men, very important. I want you to take the shield. Oh, my marker's on your... No, it's not even mine. Look at you had an arrow marker on your butt. I wondered where that went. I'm like,
it's like up over here, up
I'm
here.
grabbing your... Excuse me for grabbing your butt, but I was like, what the heck is that? Okay, so very important for men and women, you put a gonad shield like this. This is the one exception to the rule that you shouldn't see shielding within the light. Okay, the reason being is think about the anatomy. The spine's going this way, and then the sacrum's going posterior. Where are the gonads on both women and men? They're going to be anterior. So we're going to try to cut down the amount of radiation to the gonads here. There's no anatomic reason why we can't cover that area up. There's no spine in that area. Follow? Now, what's going to happen when you do this at the hospital? They're going to say, don't do that. It's in the way. I'm telling you, a good tech can shield the gonads on a lateral L spine. Now, you don't want this. That wouldn't work. But you should have like about a half an inch to an inch of light right here on the corner. And it will also improve your image because it cuts down on the amount of scatter. Because remember, what technique are we at in this area? Remember? The 3 magic ones? 80
at 1.
Okay. So he's nice and lateral. All right, the mid-coronal plane. Now, if I was doing an L spine, then where would I center?
2 inches.
2 inches above. So I'm just going to go above, and then I'll make down to 14 inches so you can see the difference. And you'll, again, see films that have both the full 14 by 17 lateral and the 11 by 14 lateral. And we can take shield to go down here. Okay, so next I'm going to do the L5S1. Now, what I want you to see here, you might want to come around to the side. His spine is curving down here because his shoulders are broader than his hip. So for me to palpate his iliac crest right here, hard to feel his. Okay, so he's pretty much perpendicular. It seemed like this morning I was going slightly cephalic on you, wasn't I?
Yeah, slightly.
Yeah, maybe it was just the way you were laying, but I'm feeling for the top part of the iliac crest and the bottom part. If I put my pointer between these two parts, see how it's perpendicular? Now, I'll just show you Erica so you can see what the difference between male and female and how you determine it. So in his case, I'm going to keep the beam perpendicular for my L5S1. So now where do I center?
2 inches behind and down.
So this is that other magic little hand trick thing. You take your first or middle finger, put it at the ASIS. You put the thumb at the iliac crest at the level of the mid-coronal plane. And then the cross for me is going to end up right in the web of my hand here.
3 and 2.
So we're basically just slightly posterior to the MCP. See that? So for some of you, it may end up in the middle of your hand if you have a small hand. If you have super long fingers, it may end up something like that. But we're at the iliac crest here. It's where my thumb is. The ASIS is where my first finger is.
2 inches.
2 inches, 3 inches.
See, ASIS, iliac crest, and you just make like an L with your hand.
No, okay.
Now, some people do it this way and use their knuckle as a guide. You know, ask the techs that you're working with at the hospital, what is their little trick for the L5S1? Go ahead. See, I would use my right hand, I guess, so I could move the table, because most table buttons, if they don't have floating tabletops, are up here, so you can move the table. It doesn't feel right for me to use my left hand. Okay, so let's go ahead and collimate. So if this is the top of his iliac crest right here, you never want the light to go beyond the iliac crest. Because what level of the L spine is there at the iliac crest?
L4.
L4. So if we're trying to get L5S1, that should be right below it. So it's a fairly small collimation, probably about a 5 by 5, 4 by 4. It says 7 by 6 here on the light. Okay. Oh, one thing I forgot to show you on the L spine. Another thing we'll do to cut down on scatter is put a piece of lead back here like we did on the T spine. You might want to do that on the L spine too. So I'm at the iliac crest here, straight across. Let me have that pointer? See how the crosshairs end up just like anterior to where the CR ends up right just anterior where the crosshairs are. Okay, again, I want to make sure and shield the gonads by showing shielding on the image here. So now I know where all my markers go. They end up going back on people's shoes and their clothes.
This is like not on MCP anymore.
No, it's just slightly posterior. Because remember, the spine's going to go like this and then back. Yeah. So you have to practice with your partner. I mean, earlier today someone was, I don't know what they were, I guess it was the sacrum, but they were like way up in here somewhere, and they could see the light wasn't in the right place, but they were having trouble palpating the anatomy. So you have to really, and it is harder on guys. I can feel Erica's iliac crest a lot easier than I can his, because you have that thicker old blythe muscle right there. Okay, so that's the L5S1. Now, at some of the hospitals, you may have seen them do this, where they bring the tube down really close. Anybody seen that? That was an old way of doing it, because if you think about the technique, this part, well, not so much on him, but on females, this part is much smaller than it is here. So we tend to go up because the part's thicker. But we've also collimated, and what happens to our density when we collimate and not change our technique? The density does what?
Decreases.
Yeah. I didn't hear if you said higher or lighter. What did you say?
Lighter.
Okay. Good. Because it doesn't get higher. So we usually increase technique, but the way to compensate for that would be to bring your tube down. For our purposes, just leave it at 40 inches. Okay? Make life simple. Now, if we had him take all of his clothes off, would you mind taking your shirt off? No, I was just kidding. You'd see the little dimples. You know how people have those little dimples? That's where your SI joint is. So you'd see the dimples right here. And then we'd also know that we're sending right through L5S1, so right below the dimples.
Oh.
That dimples that you see on people, that's their SI joint. Okay. All right, so we're done with the L spine. And we'll go into the sacrum and coccyx and SI joints now. So, before I do that, Erica, can I use you for the lateral for a second? Oh, we're still on the subject. Lateral. She always rolls too much towards the table. And see how she's not parallel to the image receptor, so I'm going to straighten her MCP so it's parallel to the table here. See that? Because she has a tendency to lay crooked. Okay, now what I want to show you here, so if I feel, look at how she's narrower in the waist and wider at the hips. So if I feel for her iliac crest, if I put a point between these two, see how there's a little bit of an angle on the about right there. Right. Okay, it's not perpendicular. So one way that you can figure out how much to angle is if you draw that line and then take your tube. You might want to come around to this side, Manuel, so you can see this. So now I'm making my line go forward just a little bit. See how my line coincides with the line that I've drawn on her iliac line? And that gives me 7-degree caudal angulation on this particular person. So we normally angle between 3 and 7 degrees depending on the body habitus. Women, you have to tend to angle. Men, usually you can go perpendicular. And occasionally you'll get somebody where you actually have to go. Did you have to with who was it, Bernie today? Did you have to actually go cephalic?
Bernie.
Because you know how Bernie's really wide in the shoulders and very narrow in his pelvis?
And then for Susan, same thing.
Yeah.
Yeah.
Yeah. So you just find your partner and find out which is better, if you had a little bit of an angle or perpendicular. So that's what I wanted to have you see is where you feel the line, then you angle the tube and adjust it to the position of the line that you're drawing between the two iliac crests. Okay?
So if it's this way, the angle caudal. If it's this way.
Right, like if I felt it like here, then we would have to angle cephalic, because that means this line would be higher than this line here.
Right, okay.
See that? Okay. All right. Okay. Do you want to stay or do you want me to switch back? We're going to do
30 for the SI.
watch out, Lana.
right there.
Okay, so I'm back to 10 by 12 cross ties. So I've angled my tube, so I want to get my tube lined up. Blocker up, down, matter? Doesn't really matter. If you don't center, you're going to get the blocker on one side or the other, so centering is really important. Okay, so I'm going to collimate down to 10 by 12 to start with. Okay. So, where do we center for the ASIS?
1 inch.
I mean, I just said it. Shoot. Where do we center for the SI joint?
1 inch.
Yeah, 1 inch below the ASIS.
SIS.
So the L5S one, we were at the ASIS, but for the SI joints, we're going to go slightly below. Because the part is slightly lower down on the body than the L5S1. So her 2 SI joints are right here. Okay, so here's her ASIS. And I'm going to collimate. You can see that the light ends up where the top of the light is above the ASIS and the bottom of the light is at the pubic symphysis. 30 to 35. Okay, and flex her legs. Just for comfort, really, because it doesn't do anything to the sacrum. Okay, so that's AP axial SI joint, and then what is the other position we do for SIs? Axial? Axial and?
And the oblique.
Right. How much are we going to oblique her?
About
25. Yeah.
25.
So now I'm not going to use this side of the sponge, I'm going to use this side. And I'm not going to put it very far under it. The bigger this back here is, the less you have to put the sponge under them. Okay? So the more the junk in the trunk, the less you have to build them up. Do you know junk in the trunk, Lida? Have you heard that term?
Yeah.
Okay, so go ahead and roll back. No, I just meant, did you know the term? Come up with it. Okay. What's happening is the sheet sliding, so when you roll back, it slides back. Let me try this again. Okay, that's better. See how every time I tried to put her up, the sheet was sliding over, so it was just taking the fat away. Okay, so depending on if it's a unilateral or bilateral, first of all, which SI joint am I demonstrating?
Side up.
Side up. So she's in the RPO. Here's her ASIS. So which SI joint am I looking at? The
Left.
So for centering just for unilateral, you put the light just inside the palpation of the ASIS. And then you're going to collimate just to that joint space. So the light should be between the pubic symphysis and the iliac crest, centering at the ASIS.
That's for SI joint.
And then which marker would I use? The left, because it's the left SI joint. If it's a considered bilateral study where they want to see both on the same film, and all you have to do is open your collimator side to side, and then recenter. So now your centering point is basically the light's going to be right between the 2 ASIS, so it ends up right just to the MSP here. And I can either still use my left marker, or because she's rolled to the right, I could use my right marker. Doesn't really matter.
Where's the center again?
At the
Unilateral?
unilateral, it's right inside the ASIS here. So here's where my thumb is. So I'm just going to skim the inside of the ASIS and then collimate like this.
Oh, okay.
But if you're doing bilateral, you need to open the collimator side to side and then recenter. So you get, what you're getting is this ASIS down and then this one open. You're looking through the space of the connection between the iliac wing and the sacrum. So for the other SI, we're going to do the same thing. So 25 degrees. So I'm not putting the sponge all the way against her back. I'm putting it about halfway, so she only goes up 25 degrees instead of 45.
30.
Shields get in the way. Okay, so again, here's her ASIS. If I'm doing a single, just inside the ASIS here, and collimate, and marker.
Is ASIS in the middle of sacrum? Is that?
It's towards the top half. I'm going to show you when we're done the pelvis on the other side where you can see the bone, and you'll get the relationship, I think. Okay. And then if I was doing bilateral, you just open your cone side to side and then recenter. So that you basically end up just like the MSP here.
And the collimation.
Yeah.
All the way to ASIS, right?
And we're demonstrating the right ASIS. And then you can go ahead and put a shield on. Okay, now sacrum and coccyx. Let's switch off for that. Okay. So I'm going to get on my side.
It's already hurting.
Now, what do I do if I tube?
Block her down.
15.
Angle 15
How much
cephalic.
is 15?
15.
So 15 cephalic sacrum, 10 coccyx caudal.
Yeah.
Okay. So where do I enter my central ray?
1 inch below the ASIS.
So here's this ASIS. I'm going to go 1 inch below and then midline at the MSP.
MSP.
Change my collimation to 10 by 12 here. Okay, bend your knees up for a minute. Okay, so see, here's his pubic symphysis. Here's his ASIS. So we're about halfway in between. It's harder to see the pubic symphysis on men because they have other junk in their trunk. Not their trunk, I guess it's their hood,
I
isn't
can
it?
touch mine if you want.
What?
I'll touch mine if you want.
Oh, no, that's okay. Because they can't do it with the patient either. But see, by flexing the leg, it helps to see where the groin, you can see where the pubic bone would be. So, here's his ASIS, so I'm 1 inch below the ASIS. So I'm basically, yeah, I'm basically between the pubic symphysis and the ASIS here.
Mm-hmm.
Okay? Alright, so we're going to go ahead and shield.
Between the pubic symphysis and the iliac crest?
No, ASIS and pubic symphysis.
Okay,
If
so
we're going
1 inch
below
below
the
would
ASIS.
be between those
Halfway,
two?
exactly. Collimate fairly close.
But is it necessary to bend the knees or?
No, I only did that so I could see where his pubic bone was. You can go ahead and relax your legs down. Okay, so I'm going to keep the shield on here. So this would be sacrum. Now, for the sacrum, I never put my marker on the patient. I always would mark this because I don't like putting my marker right here. Now, you're getting pretty personal with stuff there. Right? You have to be really careful with that. But if you put it here, you put it in too far, you risk getting it in the sacrum. So be careful, because when you're touching each other, you're like so sometimes focused on what you're trying to do that you forget that you're touching another human and there's stuff to touch. Parts, be sensitive in this area. Okay?
The collimation is about.
It's probably, well, this says it's 7 by 7.
Okay.
Okay, so what I'm going to show you is when you go from the apiaxial sacrum to the apiaxial coccyx, we're still going to center entering the same place. What do we change?
The angle down.
So I'm going to do what?
Caudal.
Hand caudally, right. Now remember on this angle indicator, each line is 5 degrees.
5
so
degrees.
when you go 10, you want to see the 15 on the other side of the red line. Okay. The other thing I have to do,
Is turn the.
Switch sides, is that?
well, at least recenter it.
Recenter
yes,
it.
take it out, but recenter the bucky when you do that. Okay, what if you get in a place where you can't move the bucky down anymore, like you're here and you can't, the bucky's stuck? What can you do?
Move the patient.
But you're already
Then
centered
move.
over here. Why move the patient again?
Change the...
Is that still not centered to the cassette?
No.
So you have the flexibility where you don't have to always have the cassette in the middle of the bucky, just as long as the light and the cassette coincide to the center. Do you see that next one? Okay, so what I did is I moved the cassette down a little bit. Okay, so let me go back to my centering point here. Now I'm not suggesting you take a paper with crosshairs and put it on your patient, but I just wanted you to see how it's exactly the same place. Okay, so now we're doing coccyx. We're going to even collimate closer. So the coccyx is about the size of my little finger here. We want to get good detail, and the closer you collimate, the better detail you're going to get, the less the scatter.
So that one's the coccyx.
Coccyx. So now we have the laterals.
Centering point is absolutely the same.
Same.
1 inch below,
Angulation.
yeah, 1 inch below the ASIS and
MSP.
At the MSP. So you want to flex the legs 90 degrees. Okay, so again, you want to make sure, because he's a little bit at an angle, I want to make sure that this part is going to be parallel to the image receptor. So I'm going to realign him a little bit here. See that? And it just, sometimes I will be literally,
I think you did it right.
yeah, like this or something, or this. By the time I'm done, the pad's like halfway off the table. When you're doing this, though, make sure to inform your patient. Just don't start pulling the pad, because they're going to start flailing around, and you're going to get hit because they're going to think you're going to make them fall, especially old people. You know, they're always
And then
afraid
they're
of
gonna hold
falling.
it.
Yeah, they'll grab that, or they'll grab you trying to, like, you know, stabilize themselves. So just make sure that you.
What about if the patient is so heavy?
Then you may have to have them move. But what I'm trying to avoid is, okay, scoot your hips away a little bit, now scoot your shoulders, now scoot your hips. That can take forever. And when you want them to move an inch, they move 7 inches. All right, but yeah, if they're super heavy and you don't have sheets to slide them, or you can't do it because they're real heavy, then you may have to go ahead and have them adjust themselves. The other thing to remember, though, is if they're in pain, they're going to have a hard time moving. Let's go back to my perpendicular beam. Okay, so now I've got this part parallel to the image receptor, so I'm going to find his iliac crest, his ASIS, here, where my index finger is. Watch, I'm going to come down a little bit. I seem to be running out of room up there. So ASIS is here, and then where's my centering point? ASIS, how far back do I go?
3 inches.
3 inches from the ASIS,
Yes.
or about 1 inch from the MCP.
1 inch from the tip.
Where's my other pointer in there?
Lateral sacrum?
Yes. Okay, so here's his ASIS. Here's his MCP. So see how we're centering an inch posterior to the MCP? Okay, this is a 10 by 12. What I don't need is all this extra light back here. So you want to collimate just inside the soft tissue. Not too close, but what you don't want to get thrown off, let me have that pillow for a minute, please. Don't get thrown off by all the junk in the trunk back here. Some people are going to have a lot of soft tissue going on back here, but you still got to keep your centering point 1 inch posterior to the MCP. Okay?
Or 3 inches posterior to the ASIS.
Yeah. But I think the MCP is an easier guideline, because if they're real heavy, their ASIS may seem farther away too because they've got fat on it, right? Mm-hmm. So the MCP doesn't change.
Just 3 inches inferior from the iliac crest?
No. Oh, inferior?
Yeah.
No, I'm at the ASIS, so that's usually about 2 inches,
Posterior.
Oh,
right?
posterior.
So I'm 3.5 inches posterior, 2 inches below the iliac crest, which is at the level of the ASIS. So this is a good sacrum here. Now, one thing you can do because of the position of the sacrum, you can turn this a little bit. Because remember, the sacrum is going to be going like this. But to initially do it, you want to keep your centering perpendicular or parallel so you can make sure you're at the right landmark here. Then we're going to shield this gonad. Okay, now notice where I'm stopping here. See how the curve of his butt is right here? Where the gluteus maximus comes together? That's where we're going to find the coccyx. Now this is not an area that we're going to palpate. On Erica you could see it a little better because she has those leotard type pants on, you know, like we saw on the slideshow the other day. You could really see where the two cheeks come together. So right now we're getting the sacrum, but some of the hospitals may have you open the collimator and center just a little bit lower, so you're also including the coccyx. They want the sacrum and coccyx together. But to do a true lateral sacrum, we're supposed to be centered at the ASIS. So now I have to go back and do a sacrum because we didn't see it. It turned out it's much smaller than the coccyx. Is going to be much smaller than the sacrum. So where do I center for the coccyx?
3 inches down.
An inch below the ASIS. Yes. So we're going to go an inch below the ASIS. Now look where that ends up. Excuse me. It's basically find the top of your trochanter here. You're going to be right over the top of the trochanter. And then an inch posterior to the MCP. Because remember, the sacrum is going to go like this, but then the coccyx goes back in like this. So they're basically at the same plane, the sacrum and the coccyx. And a nice tight collimation.
Is that like 4x4?
Yeah, or even 3x3.
Okay, so it's 1 inch below the ASIS and 1 inch posterior to the MCD?
Okay. So this would be only a lateral coccyx, not a coccyx sacrum combo. You see it? You never want to see the shadow of the body like this. If you see that, that means you've got to collimate more, because you're going to have a lot, especially when you hit primary radiation, you have a lot of scatter, and you're going to just degrade your image and you won't see anything. And really, for the sacrum, and particularly for the coccyx, we only see it really well on the laterals. Most of the time people have too much fecal matter and gas and bladders and stuff that you can't really see it. Okay, that's it for today. I'm going to show you something they store on the stamp, and then we'll have to practice, and we'll go over films later.
Spring break, open that. Okay, right.
Everybody in? Okay, so what I want you to see here is where I'm entering at the ASIS here. So here's the ASIS. Okay, so the central ray is skimming the ASIS here. See that? But it's actually, it looks like it's entering an inch below where the ASIS is palpable. And look at where it's entering at the patient. See this part right there where my finger is? What is that?
L5S1.
Yes, L5S1. So this is what we do for the hips. For the SI joints, see how we go an inch below? Now we're getting both of these SI joints. See them? See the SI joints right there? Okay, and when we do the obliques, the goal is when we rotate the patient, we're trying to see through this joint space here between the sacrum and the ilium. Okay, so I'm going to show you PA so you can actually see the space. So the RPO would be the same as what?
And LA.
And LAO. Okay, so it's the side down when you're doing prone. It's the side up when you're doing AP. So see how you can see the articulation there between the sacrum and the coccyx, the ilium? But there's part of the hip that's going to superimpose. I'll show you that side in a minute too. Superimpose, so you'll never see the lower part. You'll probably just see this open space here.
Ooh.
Okay, now I'll do it this way so you can see from that side. So see how you're seeing through this space right here? And that's the goal of getting the SI joint open. Is they want to look for, I don't know, arthritis or different degenerative process that could be pinching those nerves that cause you to get that pain down your leg. Okay? Now the other thing I want to show you is look at the level of the sacrum and coccyx in relationship to these landmarks we've been using. Okay, so if we go lateral here, see, here's the ASIS, here's the pubic symphysis. So if we go halfway in between there, yeah, see how we end up right over the sacrum? This thing's heavy. See, so we're right mid-sacrum now. if we're going to do the coccyx, we're going to go a little bit lower. So now we're an inch below the ASIS. Here's the ASIS. Got a little bit too much. There we go. So we're right over the top of the acetabulum. See that? And see how that ends up right getting the end of the sacrum and the coccyx. So it's basically, if you feel here, you can feel where the cheeks would come together right here. Obviously, we can't palpate that on patients.
That's
It's like trochanter.
Yeah, it's like right at the top of the acetabulum. So when you're palpating the patient's trochanter, it's going to be like right where the trochanter is. That's where the, see how the trochanters and the coccyx and the pubic symphysis all kind of end up in the same place? Okay? Right. Okay, it's all yours.
Okay.
Mm.